Okay, so let's talk about protozoa. There are very little sort of fundamental things that I wanted to mention about those. So, things that we need to know. First of all, of course, eukaryotes. By definition, unicellular. No cell wall. And the cytoplasm can be loosely divided into ectoplasm, the outer layer which is responsible for movement and feeding, and endoplasm, which contains all the organelles. So far so good. One really important concept, really important idea, is that some protozoa, not all of them, but some, can form so-called cysts. So they basically have two forms. It can be living, feeding, reproducing cell, or a cyst. So living, feeding, reproducing cell is called a trophozoite. But just like with bacteria, you see the strategies are very similar in the microbial world. When the environment becomes harsh, trophozoite undergoes the process called encystment. Okay, and the result of encystment is a cyst. Cysts are very resilient to the environmental impacts. They do not feed, they do not reproduce, they just sit around. When environment becomes kind of, good, conducive to reproduction, cysts break open in the process of excystment, producing a trophozoite. Does that make sense to you? Good? Clear? Okay, awesome. Why I consider this particularly important. Many protozoan infections can be started off by a trophozoite or by a cyst. Does that make sense, that statement? So you don't have to swallow a trophozoite. You can swallow a cyst and develop the disease just as well. Are we clear? Good? Okay. Few words about classification. We mentioned that classification earlier in the unit 1, actually in the beginning, that we're going to classify protozoa based on the locomotion. So we've got Sarcodina, Mastigophora, I'll explain what they are, Celiophora, and Apicomplexa. So Sarcodina would be the amoeboid movement, Mastigophora movement with the use of flagellum, Celiophora using cilia, and Apicomplexa are non-moving protozoa. Therefore, they are obligate parasites since they cannot catch the prey.
What was the first one again?
Sarcodina, amoebic motion, forming pseudopodia, like, the sort of classic biology object, amoeba. Okay? We're good?
The Apicomplexa was
Non-moving, which means, yeah, they have to be parasitic. They can't survive on their own.
What was the last one?
Apicomplexa. All right, so let's talk about some bugs. We're going to start with a few amoeba. First group is Acantamiba, various species, and Balamuthia. So this is the great example of amoebic parasites. These guys can live independently. Does that make sense? They normally live independently. They live in the soil. Those are soil amoeba. But they get transmitted through broken skin. Okay? They get into the circulation and delivered by blood into the brain, which results in granulomatous meningoencephalitis. The name for this disease is GAM, granulomatous amoebic meningoencephalitis. It's a mouthful, I know. But basically, if you break down the name, meningoencephalitis refers to the inflammation of meninges and brain tissue. Does that make sense? And granulomatous means that immune system tries to mitigate this inflammation, to restrict this inflammation, and it forms granulomas around the cells that are infected, around the areas that are infected. Am I making sense here? So if amoeba that sticks somewhere in the brain, immune system tries to encapsulate it, doesn't succeed particularly well, but limits the spread. So we talked about brain-eating amoeba very much earlier, and we discussed that the course of infection is very, very rapid, and usually people die of it. This can last for months. It's diagnosable, it's treatable, it's curable. Does that make sense? Interestingly enough, this infection is more common in underserved, underprivileged areas in the South America, for instance, in kids, because kids would crawl on the soil, and scratch the knees, and it'll get through the knees and get to the brain. Altered behaviors, headaches, confusions, hallucinations, pretty common. Does that make sense? Okay, now, this is more of an exotic disease, just to some extent. Now, infection with Entamoeba Histolytica is not. The name Histolytica kind of tells you what's going on. This is the fecal-oral transmitted infection. So consumption of contaminated food or water results in the infection of the colon. And if you look at the name Histolytica, breakdown of tissues, okay, leads to ulcerative colitis and dysentery. You may remember that the definition of dysentery is bloody stool. So far we good? Which means there's a contact between the colonic lumen and the circulation. And it turns out not only blood can get into the colon, but amoebic cells can also reach into the circulation and be distributed throughout the body. Does that make sense? Which results in the condition known as extraintestinal amoebiasis. So where in the body? Two most common locations for extraintestinal amoebic infection are lungs and liver. So this is another great example, amoebae as cells, are most similar to human macrophages. Okay, so when they get out of the colon and spread throughout the body, and they end up in the lungs or they end up in the liver, the immune system tries to block them, to restrict them. Does that make you following me? So it tries to put them in some kind of case, which results in the formation of this amoeboma. It's like a tiny little tumor, and cases were described when people were originally diagnosed with lung cancer on the X-ray. And then when they biopsied the tumor, turned out to be Amoebic, which is much more benign and, treatable and everything. Does that make sense? This is a huge problem. Like the transmission of amoeba in, poorer countries with poor water hygiene. Oh yeah, that's a huge issue. You with me so far? So I'm not talking about this microorganisms in the same order there in the notes. I do it deliberately. I'm kind of ramping up the story. So next one will be Lishmania, which is a really interesting pathogen. There are several species. Now, what do you need to know? It's transmitted by biological vector, which is a sandfly. Okay, sandflies pretty lousy flyers. They can't fly basically above the waist of an adult. They're really, really bad, flimsy flyers. But this disease, for instance, in South America disproportionately affects agricultural workers because they work in the fields early in the morning where the fly is most active. And when they work in the field, they lean forward and their face, their body kind of get within the reach. Does that make sense? So what does this disease look like? So Cutaneous Lyshmanisis is the lightest. It looks like a lesion the size of maybe a nickel with elevated edges. Does that make sense? It doesn't hurt, it doesn't itch. What's interesting is that the sandfly can actually land on that lesion. There's something that Lishmania produce that attracts sandflies, and they would land on the lesion and they would bite, take a blood meal exactly from the lesion, exactly where Lishmania is, to transmit it to another person. That makes sense? In immunocompetent individuals, good immune response, not a huge infectious dose, for instance, often cutaneous leishmaniasis is it. It can heal by itself. Okay. In some people it doesn't, and it progresses to mucocutaneous form, also known as Espundia. So this is really a risky disease because it may destroy basically structures, mostly in the nasopharynx. Okay, like soft palate can be gone, or nasal septum can be damaged, and it's really hard to restore, as you can imagine. And in some folks, Lishmania becomes systemic, leading to visceral leishmaniasis. I believe in India, the name for visceral leishmaniasis is Kala Azar, which means black fever. So this is severe, life-threatening condition with multiple organs being involved, hepatomegaly, splenomegaly, like it's bad. Okay. Now, important, it's treatable. There's no vaccine, but it's treatable. It's not considered curable, at least by the United States standards. A good example of this, during the Operation Desert Storm in 1991, many American troops got exposed to Lishmania, got infected, got treated, recovered, but they are not allowed to donate blood anymore, which removes a huge pool that can be, very important in the military operations. They're not allowed to donate blood. Does that make sense? Now, is there a chance you will encounter a patient with Lishmania? Yes. People who arrive to the United States from Central and South America may have Lishmania infection. So this is something very, very real. Okay, does that make sense? There's no transmission within the United States because we don't get exposed to sandflies much. But there is a transmission, interestingly enough, between the dogs and the southern states, mostly closer to the Mexican border. Sandflies kind of just reach over. Okay, there's leishmaniasis in dogs. Good? Okay, moving on. Our next story will be a really cool story about two apicomplexans. So these are amoebic. Lishmania is mastigophora. It is flagellated protozoa. Now, next two are apicomplexa. Toxoplasma gondii is, by some folks, considered to be the most successful parasite in the world. Infects, by estimates, from 2.5 to 3 billion people. Now, I want to focus on the transmission routes because this stuff is fascinating. So we start with the cysts, which are, let's call it an environment, but quite frankly, they are in fecal matter, which is being spread around. That makes sense? And the cysts are consumed by cows, sheep, pigs. That makes sense to you? You know, they eat grass which is contaminated and there are cysts there. So far we good, right? And then what do we do with those tasty animals? We eat them. And in many cases, some of those tasty animals are supposed to be eaten medium rare, right? People prefer them to be on the raw side, the pink side. Well, if we undercook them, cysts survive. We consume the cysts, they develop into trophozoites, then go back to cysts, and usually cysts get lodged into the brain. And interestingly enough, you're fine. Nothing happens. If you are an immunocompetent adult, that's important, immunocompetent adult, you're good. That makes sense? You're probably going to live a long and happy life and die the old age of 90, never knowing that you had actually toxoplasmosis. Good? Clear? Now, the problem comes when you're immunosuppressed. Patients with AIDS, toxoplasma is a plague for them, results in encephalitis, and neonates. Toxoplasma is one of the really important torch pathogens that are transmitted via placenta. Good? So, why I find it so interesting, the transmission route. There are 2 countries at least in the world where consumption of undercooked meat is almost a religion, Brazil and France. And the rates of positivity for toxoplasmosis in those countries is about 80%. It's fine, you know. There were some studies implicating toxoplasma infection in the road rage, like abnormal behavior, and we'll get to behavior in a minute. But I don't think we can say, well, I mean, of course, Frenchmen are crazy in their own right, but I don't think it's because of toxoplasma. Now, another interesting transmission route for toxoplasmosis is this. So cysts can establish an infection in rodents. So actually read mice, okay? And then little Jerry, when gets infected with toxoplasma, completely loses his shit and starts to come closer to Tom. Now this sort of poetic comparison. Mice normally don't get around cats because they can smell their urine. Cat urine. When they get infected with toxoplasma, we don't know because we can't ask mice, but they either don't sense that smell anymore or they don't give a shit about it. All in all, mice get closer to cats, cats catch them, which promotes the transmission to cats. Does that make sense? It's actually one of the very few examples when a pathogen modifies the behavior of the host. And then cats, they shed cysts in the feces, in the litter box. And who cleans that box? Humans. This is why, remember, it's a torch pathogen. I can put it here. So, transplacental pathogen. As a matter of fact, T stands for toxoplasma in torch. So this is why pregnant women are advised not to eat undercooked meat and not to deal with cat litter. That makes sense? Now, we're going to talk last bit for Protozoa, and then we can move on to helminths. We're going to talk about malaria. Malaria is caused by apicomplexa Plasmodium, and there are, first, big accent, big emphasis. There are different species of Plasmodium that can cause human infection. You don't need to know them. I'm not asking you to memorize like Plasmodium ovale, Plasmodium falciparum. Different species. That will be important in the conversation. Okay? And this infection is transmitted by mosquitoes. And if you looked at notes, there is a whole schematics of the life cycle of Plasmodium and in the mosquito and in the human. And it's very, very intimidating. What I'm going to do, I'm going to break it simpler. Does that make sense? I will make it sort of more conceptual, so we're not losing the forest behind the trees. So let's start with the mosquito. So culicin mosquitoes, you don't need to know that. There are malaria transmitting mosquitoes in the United States. Okay. And this mosquito is infected. They are truly infected. So this mosquito takes a blood meal, right? And gives it to a human. Okay, when mosquito takes the blood meal, where does the pathogen, where does the Plasmodium go? Which, like where? Like, what? Yeah, into the blood. I'm going to ask a lot of really, really simple questions. So, it goes in the blood, but it doesn't stay there. In a matter of about 15 minutes, so look, I'm emphasizing, like I'm telling you, this is very, very transient. It doesn't stay in the blood. It immediately jumps into the liver. Okay? Does that make sense? Once it's in the liver, this is very hard to get Plasmodium out of the liver completely. Are we clear? So what happens? Plasmodium replicates in the liver, which by the way results in hepatomegaly, and releases more and more individual parasitic cells, parasitic plasmodia, which will infect red blood cells. They have a penchant for red blood cells because red blood cells contain hemoglobin, protein source. Okay? That makes sense? And then Plasmodium will be replicating, will be growing in red blood cells. And here's an important thing. There are two possible outcomes of the Plasmodium infection of red blood cells. One, it will release new cells that will infect more red blood cells. Is that clear? Does that make sense to you? Like the whole idea. There's nothing complicated about it. Another possible outcome is that some of the replicating Plasmodia will produce gametes. So basically sex cells. And yes, Plasmodium has a male and female sex. Okay, so male and female gametes. Then these gametes will be taken in by an uninfected mosquito. Does that make sense to you? And when gametes fuse, they fuse into the zygote. Now you have an infected mosquito. You good? One more time. Infected mosquito bites human. Plasmodium jumps in the blood, rushes to the liver, settles down in the liver, starts churning up new Plasmodia, which will infect red blood cells. So they will break open red blood cells, there are two options. It will infect more red blood cells, or it will form gametes, which will be taken up by an uninfected mosquito, will fuse in that uninfected mosquito, forming zygote. And now you have an infection within the mosquito. Does that make sense? So let's talk about clinical presentation and some of the ecology. Clinical presentation. What does it look like when you get infected with malaria first? You have back pain usually, fever. That's it. Infection of the liver results in hepatomegaly, enlarged liver, tenderness in the right upper abdominal quadrant. Does that make sense? Now, check this out. When your red blood cells break open, does it sound okay? It does not. So every time your red blood cells get broken, you experience the signature malaria symptoms, which are chills, fever, cold sweat, like people are shaking, they're all sweaty, they have really high fever, tremors, all that kind of stuff. Make sense? And this happens with an amazing regularity. It can happen every 3 days, every 4 days, every 2 weeks. What determines how often? Species. So certain species, and I don't remember, and you shouldn't either, but certain Plasmodium species, listen, they will result in every 3 days. Does that make sense? Others every 4 days, others every 2 weeks. And basically a trained physician can determine by the frequency of symptoms, can basically determine which species of Plasmodium establishes the infection. Am I making sense here? Okay. Now, red blood cells being trashed, and the organ that takes care of that, the spleen. So spleen has to work twice as hard. So, like in the long run, people with malaria will have hepatomegaly and splenomegaly. Makes sense, right? Now, one important ecological term that I'm going to introduce now. There are obviously two hosts to the parasite. A mosquito is the host, right? And the human is the host. So, what's the difference? The host, which harbors the sort of sexual stage of reproduction and, gametes fuse, is called definitive host. And the one that doesn't is called intermediate.
What's the difference of those again?
So, definitive host harbors the sexual stage of reproduction, the fusion of gametes.
Okay.
Does that make sense? So, from ecological standpoint, malaria is the infection of a mosquito. Humans like just in the middle. Okay, we're good? Any questions so far? So, a few things. First, is there a vaccine? No. There are some experimental vaccines. There's one, the paper was published recently. They did an mRNA vaccine against malaria, worked fine in mice, and they want to move on to the human studies. The main problem with the vaccine is this. You see this arrow, blood to liver? It's about 15 minutes. So vaccine should be able to stop liver infection. Super quick. It's hard. Treatment. Multiple drugs. Mefloquine, chloroquine, hydroxychloroquine, quinine, quinidine, artemisinin, all good. Okay. Antimalarials based on quinine, so quinidine, mefloquine, chloroquine, hydroxychloroquine. They have one side effect, and it was confirmed by a couple of Marines who were deployed in Africa and had to take them. It gives you vivid, disturbing dreams as a side effect. And one guy that was in the class, he told me that at some point he said, screw that, I'm not taking this shit, I'd rather have malaria. Because it was so bad. Okay? Just an interesting detail. Logistical problems, delivering drugs, cost of the drugs. So one of the main mitigation strategies in Africa is bed nets, repellents, so just reduce the exposure. And here's some statistics. It's not for the exam, I'm not going to ask those numbers. I want you to have some perspective on the numbers. The annual number of malaria deaths is more than 400,000, about 410,000. 70% of those deaths are children age from 6 months to 5 years. They'd have so-called cerebral malaria, when a lot of Plasmodium end up, I don't remember the exact mechanism, basically they end up in cerebral circulation and just stop blood supply. And what's important to understand, we have a lot of people died from coronavirus. People were dying from malaria since like 80s. They keep dying every year. When this pandemic will be over, they will keep on dying because nobody cares. It's not that big of a problem for a developed world who holds all the power in terms of like pharmacological interventions, vaccines and stuff like that. That makes sense? Just a little perspective here. Questions? Okay.